Thank you, everyone. So OCT and ambiguous and doubtful lesions. So what do we mean when we intravascular imaging and ambiguous lesions? Well, firstly, it's hemodynamically ambiguous. We see a lesion and we say, look, is this significant or not? Often we use FFR, but many of my colleagues still want to use intravascular imaging. The second one, which I suppose is more useful in this context, is it anatomically or morphologically ambiguous? What is the lesion? Is it atherosclerotic? Is it non-atherosclerotic? Is it the culprit? Is it a bystander lesion? And we could do this in the context of diagnostic imaging or post-intervention imaging. When you look at about intravascular imaging in functional assessment, this is the IVUS data, and typically, as you can see, you have this wandering MLA which started at 4 and then went down to 2, so you can never really pick which the right one is, and this is the problem of using a single 2D assessment to assess the functional significance. We have similar data, albeit the cutoff points are much lower with OCT, anywhere between sort of 2.5 right down to 1.6. MLA still is the winner in the context of a 2D assessment, but often with area under the curves of around 0.7 in the larger studies, which really isn't good for a diagnostic test. Is OCT or IVUS better in this context? Well, it looks like from smallish studies that particularly in small vessels less than 3, OCT is probably better if you're wanting to use MLA. And in the larger study, based with an FFR of 0.75 or 0.8, the area under the curve for OCT is consistently better than IVUS, but still with an area under the curve of 0.7. So really, and as we all know, using a single 2D assessment to assess hemodynamic significance is really not what we should be doing. This is a very interesting study insofar as just moving out of our tunnel vision of using just single point 2D markers with intravascular imaging and looking at the plaque itself. They randomized patients to FFR guidance, and if it was positive, FFR-directed PCI optimization. With OCT, they used 75% area stenosis, so they took clearly plaque volume into consideration as well. The second criteria was 50 to 75 with an MLA less than 2.5, so a combination. Similarly, 50 to 75 plus plaque rupture, and 20% of this cohort was ACS, so very interesting. And if this was positive, they had PCI with OCT optimization. Now, the result of this was at 13 months, the primary endpoint of MACE or significant angina, and angina obviously is a soft endpoint, but important for the patient. There was a significant absolute difference, albeit it just made the cut with the p-value. And this was from a trend for benefit in all the endpoints, trend, but none of them were individually significant. It did show that OCT, you use more stents, and it was a bit more costly than FFR alone, and something that would need to consider economically. But this study really doesn't change practice, and there are many issues with this study, but what it does show is that we probably need to, if we're looking at intravascular imaging to assess hemodynamic significance, move away from pure 2D markers, expand our horizons. And this is happening in some form. We've now got work on OCT-based FFR, machine learning, and AI, and we'll have an excellent talk on AI next. Early on, this is about 8 years ago, we worked with the engineers at what was then Light Lab to look at this form of OCT FFR called vascular resistance ratio. And we gave a bunch of our patients, and in fact, VRR did much better than MLA alone. It was quiet for many years, but now they've developed this software, and there's the fusion study, I understand, that's going on. Concomitantly, we work with Shenzhen 2, who did all the QFR stuff, on OFR, OCT-based IFR, using computational flow dynamics and assessing side branch size, tapering, etc., and coming up with this OFR, and this proved really to be much better than MLA with an area under the curve of 0.93 in FFR significance. So something really to think about. They also looked at post-PCI OFR versus FFR, and that also looked very encouraging. There is now a lot of work on multiple fronts, and I suspect it's going to be a combination of OCT FFR, coronary layers, AI with plaque characteristics, and machine learning with patient characteristics that may in fact be the winner. And I think this is just very exciting that who knows, one day we may have a system where we have both an OFR, AI of plaque characteristics, and machine learning of plaque of the patient characteristics that gives us a value which will help us and not only take in physiology but anatomy as well into this. So what about anatomically ambiguous lesions? Well, in this context is diagnostic imaging and post-interventional imaging. There's a lot of publications on OCT in monochar, OCT in ambiguous lesions, and of course this is really ad hoc use, and it's best illustrated by some examples. So here's OCT in a 38-year-old male. He's smoker, obese, non-STEMI, troponin was 6, non-diagnostic ECG, and this was his initial angiogram, and you see a mid-RCA stenosis. So we thought we'll put in a guide catheter, give some GTN, and that disappeared. Some mild tapering. So the fellow said, and it's unusual for a fellow, look, it's spasm, let's just stop. But is there a lesion here? Anyway, so we did OCT. I'm sure I don't think I can stop this, but if you look around here, just coming up, here you can see clearly this is thrombus, fibrotic plaque, and this is typical of plaque erosion. Follow up a few months later on just medical therapy. In the interest of time, they were meant to make me able to move this, but it's not working. Anyway, there's just essentially layered plaque. Next patient, 46-year-old male, smoker, moderate untreated dyslipidemia, usually fit and active, chest pain with anterior ST elevation in the ambulance. They gave him DAPT, GTN, and heparin in the ambulance. By the time he arrived, his ECG and his pain had resolved. This is what we found. There's something here in the proximal LAD, which is a little bit difficult to see, but certainly some tapering there, so we did an OCT, and that's our OCT. You can see there's a little bit of irregularity there with plaque, but absolutely no thrombus there at all. So there's proximal LAD plaque, no clear disruption with thrombus to explain an end-stage. So this is what we did. That's the baseline LAD. It's a bit of ergotamine, and that's really nasty to have in the cath lab. That's his right coronary artery with a bit of ergotamine. So he was primary coronary spasm with underlying stable coronary artery disease. Again, a significant difference in management, and in fact, he subsequently returned with right coronary artery spasm. So 58-year-old male, hypertension, dyslipidemia, presents with a non-STEMI, settled with the usual antithrombotic therapy. This was a lesion in the LAD. But the RCA also had a lesion. So which is the culprit? So we did OCT on these two. LAD, you can see here, thrombus. This is the culprit, typical appearance of erosion. This is the RCA, which is probably even more interesting. And that's the appearance of layered healed plaque, and quite fresh too. So he's had a disruption on the right quite recently. So he's a high-risk patient, will need aggressive secondary prevention therapies. And in this context, the operator just entered the LAD and medical therapy for the right. So two similar ambiguous lesions. LAD was the culprit for ACS and erosion, but the RCA was a bystander with layered healed plaque. What about post-PCI, these ambiguous hazy shadows? This is a patient who had that mid-proximal LAD stenosis, had a stent done by my colleague. He said, look, I've got something unusual going on here, something a bit hazy. So this is the OCT frames, starting off just from the proximal end of the stent. And as you can see very clearly, there's a bit of lipid-rich plaque coming across here. Same lipid-rich plaque. He's got disruption and thrombus, and that's complete geographic miss with really the culprit plaque being entirely proximal to the stent. What about when you decided not to do OCT? In fact, this was the same operator. Presented with an ACS, that was a baseline coronary angiogram, put in a stent, and this is what happened. Now, in retrospect, this person was clearly someone who was high risk for this. This is the OCT, that's distal to the stent, very clearly that's SCAD. Proximal to the stent, that's here, you can see now propagation of the hematoma and compression of the lumen with SCAD, which even goes up proximally beyond the diagonal. So ambiguous and doubtful lesions, time will tell if OCT, FFR, machine learning, and AI will make OCT a valid tool versus FFR and IFR. It's exciting times really with the technology into the future. It's invaluable in patients with anatomic ambiguity, and we've had many examples, and we'll have many more at the rest of this meeting. The bottom line is, if in doubt, image. Thank you.